You're listening to the Patient Advocacy Now podcast, presented by Greater National Advocates.
It's just gut-wrenching sometimes. Like, if it's sad and they're crying, I might cry.
Amazing how many doctors do not even want to treat somebody who has Medicaid.
Medical system is about making money.
And I said, so are you hiring more nurses, or you're just telling each nurse to work harder?
Andrew Gill, thank you so much for joining us. I read through a lot of your background before we started, and obviously this is an area that I'm incredibly excited to talk about, and I know a lot of the people listening, a lot of the advocates listening can use some more information. You kind of, as a licensed professional counselor, you kind of sit with people who one of your specialties is dealing with chronic pain. Is that right?
Yes, so I've had several clients with chronic pain issues, and being able to make applications for therapeutic intervention, kind of assessing situations, even walking with them through hospital situations, triaging different needs in context of body, mind, and even spirit. It's been something that I've done throughout my career.
How'd you get into this kind of specialty or this population? Because it's not so common for counselors to kind of be in this area.
Well, I would say, John, that it came to me. I'm very open when it comes to my invitation of clients. So I take all kinds of different people into my practice, and this specialty kind of came from learning from what came my way. So it was actually an interesting adventure to experience that. And I would say also being on insurance panels helps, because, the referrals will come from, I have different panels from commercial to traditional Medicaid as a provider. And so, folks are struggling. And so, chronic pain issues do come up. There's, we've got a lot of mental health and chronic pain. We've got 35-40%, of, that can be intertwined. So
say that again. 35 to 40% of people with chronic pain suffer from mental health issues.
Yes.
And how does that manifest? What kind of issues are you seeing typically?
Oh, well, it ranges, but predominantly there's a lot of anxiety, a lot of stress, very anxious because don't know what the body's doing. And then, a lot of abilities have been taken away, in the process of chronic issues, but, it's different medical issues that are occurring or pain. And in those situations, it can be very depressing, with the loss and the grief from all the limitations that come with it. And the life that I had and the life that I have now, there's a lot of adjustment in that process that makes it very demoralizing. And then you deal with the medical system that we have, which is, also very frustrating with this. It's very specialized, and, all these, people don't talk to each other. And they also don't know about the special issues that go along with certain chronic conditions. And so it makes it very complicated. And so I think that all those things, anxiety, depression, trauma, a lot of people are traumatized by even their medical experiences, not being heard, not listened to.
Yeah, the empathy component there where people, you're kind of rushing people in and out of a hospital at 15-minute intervals with doctors. And so it's difficult to feel like anybody actually cares, I'd imagine.
Well, I think that it's kind of a challenging thing based on my experience with, working with clients that are going in and out of hospitals, is that some nurses are really caring, but they may not have the right medical knowledge about the condition. And so they misunderstand it. And some of the system issues, a lot of times, it's not even like that the nurses may not care. It may be that, the nurses aren't able to understand what's going on, and they handle things in a certain procedure in the hospital. And so they become very focused on, well, I don't want to, not follow my procedure, but they don't realize that these may be special situations that need the doctor's, guidance, or, do I need to call someone else, or do I even need to call an advocate of this person? and understand what's happening with them.
Let's talk about the way you work for a second. I mean, you brought up a lot of good points, and I just, knowing what I know about working with people in the room, on the couch, per se, even though I realize a lot of it has become telehealth these days. You kind of have a very holistic approach. You use kind of body issues with somatic therapy. Kind of the gold standard that I'm familiar with, that people kind of learn as a psychotherapist, is cognitive behavioral therapy, CBT. Why do you feel that falls short, and what do these other kind of modalities bring to the table that help people?
Yep. Sorry, did you cut out there? Okay. So I think that the best way to understand is that we're not just dealing with like beliefs about ourselves or just cognitions. We're not just an intellect. We have an emotional system, and CBT does have a framework for emotion focused therapy, if you're familiar with that.
Mm-hmm.
But we also need to understand that when there's medical issues involved, we're talking about limitations of the body. Or when we're talking about pain, we're talking about pain receptors. We're talking about a physiological system that is, interconnected with our brains. So it's not just going to be, a matter of changing our thoughts about things. It's also going to be talking about like, well, how are we holding our emotions in our body? And, how can we be more aware of the experiences that we're having? Very common for chronic pain or chronic conditions that we dissociate. We check out. We don't want to deal with our bodies. And so this somatic therapy is in somatic, approaches, body awareness, including relaxation exercises, and just really mindfulness strategies, really being in tune with what's happening and checking in with body scans, are just so important for this population. And, doing cognitive therapy, just telling a person what they need to think, is very dismissive. And it basically undermines their whole experience. And instead of integrating the somatic with the cognitions, right? So, being able to like start kind of like bottom up, so to speak. Being able to like be in tune with the experiential aspects of what's going on with the person, and then moving towards, shifting of mindsets or perspectives.
I like the way you said bottom up. That kind of makes me think. I've had a lot of people tell me that, most intellectuals that you meet live from the neck up, which I've never completely identified with, but it makes sense. If that's who you are and you're seeing someone right in front of you, you're going to deal with the neck up, and that just isn't the whole picture.
No, it's not. Yeah, I agree with you.
So what kind of, other than somatic work, and you've kind of talked about, for people who aren't aware, somatic meaning in the body, right? So body work. So you talked about relaxation exercises and mindfulness. Other than that somatic work, what other tools do you find helpful for this type of population that you work with?
So, well, I'm trained in motivational interviewing, which is, Miller was the one that developed this technique in New Mexico. And, this motivational interviewing was, predominantly used initially for substance abuse users, but it was also used for the medical profession, which was really interesting. So just for any kind of medical condition. So I think motivational interviewing as a strategy, which, by the way, I was trained by Miller. And so I've been able to integrate that motivational interviewing approach to engage people. And essentially, the fundamentals are this: that you want to be able to meet people where they are. You want to listen to them. Mm-hmm. And, motivational interviewing has a very person-centered approach towards it. And, people feel overwhelmed. There's a lot of different things that come at them, and they don't want to, be, solution focused therapy, for example, be a little bit too much. It's like, that kind of overwhelms a person with all the solutions. They're being told what to do, And so I think that motivational interviewing backs it up a little bit and is being present with the person meeting them where they are. It also is very accepting of the ambivalence of these situations. When we talk about ambivalence, we're talking about feeling two ways about it. I want to do the treatment. I don't want to do the treatment. I want to take my medication. I don't want to take my medication. I want to go to the doctor. I don't want to go to the doctor. I want to eat well. I don't want to eat well. These are all the ways that people feel. And being able to sit with a person with that ambivalence is really essential to let them explore that and help them to be able to build their own self-efficacy.
Walk us through what motivational interviewing looks like, what it sounds like. It's, everybody understands both components of the title, motivational and interviewing, but unless you've actually sat through it, I think it's a little bit kind of muddy and murky. What does it actually look like in practice?
Yeah, so it is a little bit involved, and probably could be worth another podcast, I'm sure. But open-ended questions instead of closed-ended questions is a fundamental concept of technique. What would be most helpful for you right now for me to talk about motivational interviewing? All right, so that's an open-ended question. What's a reflective listening with emotional attunement? For example, John, you really want to know about motivational interviewing. That's something that interests you, and you can see how that would be helpful to chronic pain, people that are in chronic conditions or chronic pain. That's reflective listening. There's also this element of rolling with resistance when there's those moments when I don't want to do something good for myself. I'm overwhelmed and distressed, and I'm just fed up. And you're really struggling right now. This is really difficult for you, John. You're having a hard time, understanding motivational interviewing right now. So that's rolling with the resistance. And then you're eliciting change talk. You're wanting to help a person to be able to move towards that healthy behavior change. Like, John, you're really thinking about wanting to use motivational interviewing in your own practice. You're really wanting to, implement this with some of your clients.
Got it. So there's a lot of that empathy and validation to make the person feel seen and heard. And then there's kind of that gentle nudge that comes in as an undercurrent once there's kind of that connection between the two of you. Does that sound right?
Yeah, absolutely. I think that's really essential. You want to build that rapport and that empathy with these strategies. So, they're intertwined where the spirit of motivational interviewing is that, right? That, you're not just like, trying to shift people to change, but you're really being present with them and really empathizing with the struggles that they're going through.
So fascinating. What kind of, do your clients come in with goals in mind, or are they just at a loss and they don't even know where to start? What does it sound like when you first meet a client?
John, I like your question. So I've supervised a lot of clinicians, and that question has been asked a lot of times of like, what do I do my intake, with them, and what do I do in the first session with a client? And from a motivational interviewing perspective, I typically defer a lot of my judgment in my first session. I usually don't go over a lot of information, unlike what they suggest. I actually sit with them and I hear what's really going on with you. Can I just be present with you and what's happening? And, kind of like reflectively listen and be present. And then from that place, come up with what their presenting issues are and how to engage with them. And I think that's true for advocates too. They want to be able to get into that position of just listening and not necessarily come with an agenda, right? But be present to the person and be able to, like, Edith Stein says this. She says, we truly are able to empathize with the other when we have an experience of the other as an embodied person. Okay. And so when we can encounter that person fully as they are, we can truly empathize with their experiences and also suffer with them. Counseling is suffering. Advocacy is suffering, but there's meaning in that suffering. And so, when we're really being good helpers or advocates, we are engaging with that process of, enduring people's sufferings with them.
And how do you handle all the suffering for people who don't do this work? Because it sounds intimidating, right? If I were to go up to somebody on the street and they say, "What do you do for a living?" I suffer with clients, right? If you were to sum it up that way, I know there's much more to it, but how do you handle that on your end? Because a lot of advocates who aren't trained in the mental health space, but find themselves sitting in this uncomfortable place with their clients, I'm sure the toll is quite high. And maybe there's some advice you can offer to the advocates who might be listening.
Joe, I want to tell you this. When I started off my career, I worked in a drug and alcohol rehab. And, early on in my career, it was very difficult to differentiate the boundaries. Really helped me to understand, the feeling responsible or not feeling responsible. So I think that's something, especially for addicts that are out in addiction processes, that they're struggling. And, the rates are really low for recovery for addiction. You get about 30% sometimes, and you get about 70% that it doesn't matter what you do. Sometimes it just are going to go out and use. Yeah. Right. So you learn really quick about how to shift out of some degrees of responsibility for people's behaviors. So that's the fundamental thing is I'm not responsible for other people's behaviors. As a helper, I'm responsible to a person. Right. And then, good book, Boundaries, Townsend and Moore, I think is, taught us those kinds of things. So I would recommend that book for any advocate, by the way, because it would give context for that. But I think for me personally, how do I manage, well, first of all, I want to say when I'm dealing with chronic conditions or chronic pain clients, it is another ballgame. It is different than my other clients. It is more intense. It involves them in being in hospitals a lot, and it is hard work to ebb and flow with it. I will say this, that I am going to go out of my way to talk to hospitals. So I'm going to be a good collaborator. That may, I'm going to be in crisis more, right? So I've kind of taken that as something that is going to be part of the job when I work with this population. So it's an acceptance. I think that's really helpful to know, is that there's a certain degree of acceptance that I know that that's part of it if I'm going to work with this population. But the way that I take care of myself is that I really turn off. After I deal with a crisis, or after I deal with a case where I'm working through some somatic work, where it's really distressful with the person, work through some shame, work through some trauma, I'm going to turn off after I get off work. I'm not going to allow myself to, spend time on the case in my brain.
I think that's an important lesson for not just advocates, but a lot of nurses as well. They don't spend a lot of time training how to keep those boundaries intact in the mental health profession, which is why you see so many surgeons and doctors and everybody who also struggle in their own ways and often in silence. But yeah, we don't talk about it enough, how the advocates need to understand that those boundaries need to be created that are comfortable for you. And I like the way the way you kind of reminded us, responsible to a person, not for a person, is a key part of that. Talk to me about what you wish advocates knew about chronic pain and mental health, and how you wish they would approach it maybe a little more often.
Yeah, so I think, early in my career, I worked with a woman named Dr. Benish, and she taught me, the first thing that you do in general is assessment. So if you don't have a really good assessment of the situation or assessment of the needs of the person, then it's really, you're not going to make good interventions or advocate appropriately. So I think the recognition point here is you really want to understand the assessment of the situation first before you proceed into the next step. I think it's important also to realize that there's this interplay, right, that we have with mental health and chronic conditions. And I think we can't generalize. It's very unique to the person. And so I think that that's a really important point for advocates to understand, that when you don't want to label or get into generalizations of any given person or any given condition, because all of them are special. And I think it's not just mental health, and it's not just mental conditions. And sometimes I've had doctors say, well, it's just psychological. And it's not. It's actually a medical issue. Or sometimes it's a medical issue, or a psychological issue, and they're not taking that in consideration when they're thinking about how it's impacting the body, right? And so I think you don't want to get into like this dichotomy of just labeling things and generalizing things into like these categories. You do want to keep it together, right? And understand that it's complex, and having said that, you also want to keep it simple. One of the things that I recommend, I also studied under Dr. Benish organizational psychology. So, and one of the things that was fundamental to understanding is like, you've got to understand systems. We have a very, very difficult medical system today in America. I spent some time in Brazil one time. I was at a wedding early in my career. And in this hospital, they had a social worker. They had the doctor, the nurse practitioner, the nutritionist, the counselor, and the social, all these collaborating together in one system for one client. And I was like, that was an amazing encounter to experience a comprehensive system that covers all their bases. Very integrative, very interwoven. Our systems are not like that. And it's important to understand that that is the way it is. It's not the way that it could ideally be. That's the way, but this is what we are dealing with. And so we've got to work within that system and educate certain people on, advocates need to educate on what's happening. And I've seen, even advocates that you're associated with do a really good job of that, of saying, look, I'm filling in the gas for you. You don't know what you're talking about. This is what's happening with this person. Please listen to the client. The client's telling you something very important. So I think it's important to keep it simple as well when you're working in these systems, to understand that you do have a say, and that the client does have a voice. And as complex as it is, you can be effective by being a voice for them.
Yeah, there's advocates that kind of have stepped up, and one of their primary roles is that coordination of care that's missing in America. And that's really, they're just quarterbacking the different specialists and mental health and social workers because there isn't a lot of vertical integration in that respect. And you're right, it is complicated. One of the things you talked about in terms of assessing and how everybody's unique, I think it's a great point. If a new advocate is listening to that, though, I feel like it might be overwhelming, right? At this point in your career, it might be intuitive, right? I'm going to assess for this, I'm going to assess for that. But if you're starting out, how do you know you're assessing the right places? Do you use a checklist in your mind, or kind of a rough checklist? How do you go about doing that?
John, I think you're absolutely right. I think, in general, assessment is very overwhelming because there's so much information. I'll just say this, that, when I started my career, just like you mentioned earlier, clinicians are not always trained really well. And a lot of times you learn on the spot. And I think that that's also the case for advocates. They're doing a lot of learning about, people's experiences on the spot. And so I think that, what I mean by assessment is being able to understand what the client is communicating, and also, referencing what you already know, right? And so you can only assess within the scope that you know, okay? And that's okay. You're not going to know everything. The heart of this is that you are advocating, right? And so I think that you can, take back the overwhelming feeling by realizing that there are things that you can do, even if you can't do it all.
Yeah, it's a great point. Can we go back to somatic therapy for a second? I have a couple kind of, it's not so widely adopted here. We're definitely making strides. People like Bessel van der Kolk are, writing books and trying to explain how the body does keep score of trauma and whatnot. Why do you think we're so slow, especially here in the West, to kind of adopt this somatic kind of framework and paying attention to the body, especially in the context of suffering and pain and what are normally looked at as mental issues?
I mean, you've probably asked a question that we all would like to know. I think ideas have consequences. I think that fundamentally we started in the world of psychology with a lot of like cognitive therapy, especially in America. When psychology was developing, there was a lot of we call it now like negative psychology, where it was symptom focus. It was very orientated towards the problem. Okay. And then we see some more like, when we're thinking about let's discover the problem, then you think through the solution, right? And so I think the early stages of American psychology was very orientated towards that model of finding out what's wrong with the symptoms. Let's correct the symptoms. Let's figure this out and problem solve. I think we've moved towards more Van der Kolk and, the body keeps a score. We've, EMDR therapies, somatic therapies. We've moved more towards that alongside of what's called positive psychology. Positive psychology is more personalistic. It's more orientated towards the integration of the whole person. We're not just looking at, at the thoughts and, energy does follow thought, right? So there can be results from that. But there's much more to the story of how we hold emotions in our body, how body memories work. And also, we are so cerebral in this technocratic society that we're in. Everybody's on a screen, everybody's analytical. And this mind-heart connection that we hear so much about, that we need to allow our thoughts and our heart to connect. That it connects in an embodied self, in a sense of that. And I like to reference again Edith Stein. Edith Stein, talks a lot about empathy, and she makes reference to the fact that until we have an experience of empathizing with our own bodies, we can't truly empathize with other people. And I think the somatic work is so important, because not only are you being aware of what's happening with your body, the sensations in your body, the feelings that you're having, they also tell you your needs, right? I'm hungry, right? When I know that I'm hungry, I'm in tune with my body, I eat, right? On the basic level, this also works psychologically. If I'm feeling alone, that tells me I want to belong, There are different things that are when we reference our bodies, they tell us something about ourselves. And that's really important, especially as it pertains to when you're in a chronic condition or chronic pain. I mean, look, my clients that suffer in this way, oftentimes it's hard to even access that. I almost want to get rid of my body because I'm sick of it. Right. Yeah. But being in tune with it and being able to accept your body as it is so key to being able to, be in acceptance of yourself.
What kind of transformations do you see sometimes when you do this work with your clients? Is there a sense of acceptance? Is there a way to cope with the pain more? Is there more of an awareness? I know it's not going to be a one size fits all, but what kind of impact have you found your clients having as a result of embracing these approaches?
Well, I think number one, there's a lot of like what I would call imposed narratives that people have. Okay. So I think that there's, what I mean by that is there's typically like, I'm a failure. And because I'm a failure, I'm not going to bother with taking care of myself. Okay. That's an imposed narrative. Okay. Yeah. So I think that there's a lot of like those kinds of patterns that people have, developed, either socially, interpersonally, or personally. And so I like to deconstruct those, and be able to help a person to, come to the realization that, there's a need for self-compassion here. Like let's remove the critical self. Let's shift to a compassionate mode towards your body, towards you as a person. And then let's also survey, again, that awareness, like you said, awareness of the body, awareness of the needs that we have, and how to meet those needs in a healthy way, right? And a big piece of this, the transformation that I see is like, we want to see the gradual, number one, we want the mental health symptoms to go down so that we can reduce their impact on the body. because the more anxious you are, the more you're going to have the, severity of conditions, physically, right? Because that mental stuff will impact the physical. Yeah. So that I want to see that, if that's treated, then we're going to see a reduction in the physical symptoms. And that means less hospital visits, right? Yeah. We're always excited when there's less hospital visits.
Sure. Even the hospitals are excited when there's less hospital visits.
Yeah, that's great too, right? But overall, like what you said about, being aware of oneself, being able to unscript those things, script healthy things into place, acceptance of self. And also, I love the support systems for chronic conditions. I love these groups. I want these groups to thrive. I want these, people to feel like they connect with other people that are suffering the way they are. Why? Because that builds meaning, builds purpose. It builds like, these people understand me. These people, I want them to feel that. I want them to be able to feel like they're not alone in this suffering, and that they can live a healthy life still with it.
Yeah, we see that a lot, even with who becomes an advocate, right? A lot of people become advocates after their parent or their child or a loved one becomes sick or has an accident that's traumatic, and then in becoming an advocate, that suffering has an elevated sense of meaning and purpose that drives them, and they're able to help. So many people as a result, as well as healing the broken part of their kind of soul that hurts from their own loss.
That's right. Absolutely.
In your talking to clients who are kind of in and out of the hospitals, are you seeing things that are happening in the hospitals where you're like, I wish they could get this fixed? I know that we talked about the splintering of the medical system and how it's kind of just kind of spread out across different fields that just don't talk to each other. Is there anything else that you're like, man, if they could fix this, my life as a clinician would be much easier?
Well, it's a loaded question. There's multiple factors that play into our system. Again, I think at this point, I'm really in acceptance of the fact that the system is the way it is. So I don't expect a good service. I expect a bad service for my clients, and that may be sad, but I have an acceptance that they're going to go into a bad. They're going to be misdiagnosed. They're going to be misunderstood, and they're not going to be heard. And that's unfortunate that I have that attitude towards the system, but it's kind of helped me a lot to be able to say, okay, this is the baseline. I don't go in with the expectation that they're actually going to do their job. I don't go into the expectation that they're actually going to be giving the right treatment even. Now it's always surprising when it does, and I give them credit for when that occurs. I'm like, yay, that's wonderful. But I kind of go in with the baseline of they're not going to do their job, and I'm not cynical about it though. I really do have a disposition that, well, these are teaching opportunities for these professionals. These are, ways in which, there can be clarification. But I will say the biggest barrier that I found, I've called into hospitals and I've said, I am their licensed professional counselor. They have me on file. Can I talk to the doctor or the nurse practitioner?
Right.
I go ahead and assert my authority as a licensed professional counselor, and I know the advocates can't always do that, but I do. I just go in there and I say, look, this is not what you're dealing with. This is the situation. This is the diagnosis. This is what my client's telling me. Can you clarify? And I seek clarification. It's the approach that I take with these systems. Now, I also give them credit for the things they do. I'm like, thank you so much for what you're doing for my client. I really appreciate that. But I think that kind of disposition of just understanding that a lot of people don't know, and they certainly aren't going to know the mental health piece, and they may not know the nuances of the medical condition, especially when it's a very sophisticated medical condition.
Right. I kind of plucked out two things of what you just said. One is there's this accepted sense of pessimism. And I had a friend who told me once the good thing about being a pessimist is you're either always right or pleasantly surprised. And you kind of embodied that really well. But the other part was like, look, the doctors and the nurses and the staff at the hospital, leading with a little bit of a smile and a little bit of warmth doesn't hurt. They have a hard job too. And even though they're not doing it, perfectly, a little bit of gratitude goes a long way to try to get everybody on the same page, and asking for clarity instead of offering criticism is going to get you much further every time.
Absolutely. Well, sometimes you do benefit from being obnoxious.
When do you find, is there like a line that gets crossed somewhere in your head where you're like, okay, now I get to be a pain in the butt?
Yeah, I think it's the point when I notice that they're not listening to me either. When they're just following a procedure, but they're not seeing the exception to the rule. And then I play my cards. I play my cards in those instances that I can report them, and that I know things that they don't know, and that it works to their disadvantage. And then all of a sudden they start calling the doctor.
Surprise.
Surprise. All of a sudden I'm talking to the doctor. Oh, wow.
Yeah. And that's also something I think that develops over time, right? So as an advocate or as a licensed mental health professional, it's when do I push, and knowing instinctively like, okay, now I'm being given the runaround, I'm being avoided, I have to kind of lean a little hard, and it's for the benefit of my client, right? I'm really just trying to be of service to them.
We'll say this, that usually when I'm in that obnoxious mode, my obnoxiousness is not emotional.
Right.
It is actually a obnoxiousness that is actually, playing their procedures with their procedures.
It's like when an attorney gets pulled over by a policeman and they just start reciting the law. It's like, this is what's going to happen next. And then people realize like, he's got me. I gotta
have correlations on it. Yeah.
It's good advice. What do you feel? Let's say I was an advocate and I had a client that was suffering from a chronic condition that has quite a bit of pain and challenges. How would I go about referring them to someone like you? If they're in Texas, I would just refer them directly to you. But I don't know if you have the ability to practice outside of your state with telehealth, but who should they be looking for? How should they be kind of encouraging people to look for someone who is a specialist, even in the, the therapeutic world, the mental health world, that could help them with something like this?
Yeah, so intake for any counselor can be very difficult in general. Are they accessible? Are they not accessible for that kind of work? So, do they have, availabilities to, address crisis counseling as well? So, if there's things that come up, will they be able to, engage and collaborate on things? So not everybody wants to do that as a counselor. In fact, a lot of counselors don't want to do that. Yeah. So will they have the heart to advocate for you as a therapist, even work with other professionals? It's extra time. It's extra effort to put into these things. So I think that's one of the things that you want to ask the therapist, right? Is, are they willing to, help if I have a crisis? Yeah. I think usually something like Psychology Today will have chronic pain or chronic conditions as one of the topics. So you can start
with like a filter. So like when you click on like specialties, chronic pain might be an option.
Yeah.
Yeah. That's good to know for people. Yeah.
I think so. I think it's really helpful because you can navigate that where they have a specialty in it. I think also people are looking for insurance. I mean, these are expensive things for, dealing with medical issues, and at a baseline, it's about cost, right? Am I able to afford the therapist? Right.
Well, especially if it's going to be a long-term relationship and you're seeing them every week. Yeah, I would, because it's a chronic condition. It's not like you're going to come in 3 times and get some advice and go home,
Yeah. So, and this is the challenging aspect is, like I'm on traditional Medicaid, and a lot of Medicaid managed care systems like Superior Health, Molina, on and on, some of the managed care systems for Medicaid. So, and that's where a lot of these, needs is in this system, but there's not many clinicians. Not many people want to take Medicaid,
Yeah.
So this becomes more difficult to find the right insurance panel and match it. So, if I don't have their insurance panel, I won't be able to see them. Right. So
why do you feel like so many clinicians are resistant to working with Medicaid? Is it just the extra work, the extra paperwork? Is it the reimbursement rates not being high enough? Is it all of it?
Yeah, I mean, I would say I don't know their reasons. Those could be all the reasons. I would say I can tell you my reason for being on it, and it's because I started out working with more impoverished populations, and I'm not suggesting that this population is impoverished. I'm just saying that like I saw that there was a need, and I really had a genuine desire to serve the need. And I think that that's why I got onto Medicaid in general, is because I don't think there's as many people doing it in our profession. And you hear a lot in our profession. Well, it's important to advocate for people. It's important to advocate for mental health. And so I kind of felt it as like it's not for everybody, but for me personally, I felt like that's something I can do for some people. I have a high level skill, and they don't get that. So put me on the panel, and I may take a pay cut, and I do. I mean, it might, the rates are way disproportionate from my private pay rate.
Yeah.
But I take that because, I think that there's like also a duty in our profession to advocate for people.
Yeah. Well, you walk the walk. That's for sure. Put your money where your mouth is, and your time too.
Yeah.
All right.
It may affect my finances, but maybe I get a crown in heaven or something.
Yeah. Right. The attitude. I think a lot of people get into this profession with the same attitude. It's like, well, yes, I mean, I want to live, but I also want to serve. If you're not called to serve as an advocate, as a clinician, then you kind of have to start wondering, well, what is the motivation?
Yeah.
You can go be a banker. Yeah.
Very true. Good point.
Do you have any last words of advice? Or, I mean, I don't know if your caseload is full and you're open to taking clients, or if it's kind of a revolving door, but if someone wants to get in touch with you directly, do you want to kind of give a little bit of a heads up on how they could do that?
Yeah, absolutely. So yeah, I actually in Texas, I'm not licensed anywhere else, but in Texas, I do telehealth. I am available currently. I think maybe in like 3 or 4 months, there may be a shift that occurs with new markets. But I am available currently, taking new clients. And one of the nice things about my service is that I have an online scheduler. So, once, clients do make contact with me through email, then I usually try to screen their insurance or, process things with them and, get them into services and help them out. But yeah, I think in general, if you're in the DFW area, that's where I'm located, here in Irving, Texas. So, but yeah, I think that be more than willing to take anyone that's in need at this time.
How would they find you? Do you have a website or?
Yeah, so my website is tauhealingservices.com. It's TAU healingservices.com, and my email is tauhealing@gmail.com. That's again TAU.
Andrew Gill, thank you so much for your time.
Thank you, John.